So as we heard from Mark, as he said memorably, the future is going to be different in healthcare. The only question is, when does the future arrive? I would say about now is a pretty good time. And as you heard further from Mark, as we seize upon this future, the triple aim of better healthcare at lower cost becomes utterly essential. As he mentioned, the system is moving now on several fronts toward a more personalized system, targeted around, as we know in some instances, even our individual DNA. A more technology-driven system focused on capturing the benefits of digital, telemedicine, et cetera. A healthcare system focused more around teams, where every member of the team is working essentially at the top of his or her license, and a system focused on transparency around price and outcomes. And as he asserted, the IOM said several years ago, nurses have to be at the center of all of this, and again, working at nothing less than the top of their license. He mentioned the enterprises already recognizing this, the more than 1,500 retail clinics, the businesses now that are having their own on-site clinics for employees, the organizations that are providing care for frail patients, particularly those in advanced stages of illness, and those who are working to coordinate care as best as possible, get rid of preventable readmissions, and all the other things that we know are sucking waste out of our system. We're going to hear from some of those organizations now that are doing precisely that are contemplating the other changes Mark said are needed, like continuing to attack scope of practice, like continuing to undergo payment reforms that enable organizations to make the best use of people working at the top of their licenses. And let me introduce them to you briefly now and call them up on the stage. First of all, we'd love to have Trish Annan join us. Trish is the Vice President of Clinical Services at Metropolitan Chicago Healthcare Council. Trish, welcome. Also, we're delighted to have Kevin Ronneberg. You heard Kevin mentioned earlier. He's the Medical Director at Target. We're also happy to be joined by Andrew Sussman, who's President of CVS Minute Clinic. Welcome, Andrew. Randall Krakauer is with us. He is the Vice President and National Medical Director of Medical Strategy at Aetna. Okay. At least one Aetna beneficiary here today. I'm sure many more. And Mary Paserno is with us. She is Chief Nursing Officer and Premium Solutions Lead at Cigna. Great. Well, welcome to all of you. And I also wanted to mention, for those of you who are denizens of the Twitter sphere, if you'd like to tweet out about this panel, please do. It's hashtag #AccessToHealth. So welcome to all of you. It's great to have you here. And you are all leaders in your own way in this effort to achieve the triple aim. And you each have, as we know from having talked with you earlier, lots of ideas about how nurses can help you improve care, achieve better outcomes, and lower the cost. So we thank you for coming to share your experiences with us today. I wanted to ask each of you to just take a few moments to address and set out for the audience how your organizations are using advanced practice registered nurses to improve the bottom line and improve care. What are some of the barriers that you're encountering and that prevent them from being fully deployed, and how you'd like to see those barriers dismantled or other changes made? So, Trish, love to start with you.
Great, thank you. My name is Trish Annan, and I'm the Vice President of Clinical Services at the Metropolitan Chicago Healthcare Council. It's a large membership and services organization in the Metro Chicago region, known as MCHC. I'm responsible for emergency preparedness, clinical services, and the Center for Advancing Provider Practices. Prior to coming to MCHC, I was the Chief Nursing Officer and Chief Operating Officer for organizations throughout the Metro Chicago region. And through my former role and my current role working with 170 member organizations, we found that with the change, with the Affordable Care Act, the changing healthcare environment, that we needed data-driven research on what was going on to enhance the provider team and look at how the roles are changing. And so MCHC, with the University Health System Consortium, which is the hospital association for all the academic medical centers, we developed the Center for Advancing Provider Practices, commonly known to many as CAP2. CAP2 actually is data from 130 different organizations. It represents 19,000 advanced practice nurses and PAs from 25 different states in 50 different clinical specialty areas. So we don't deploy advanced practice registered nurses. What we do is provide data about what is going on around the country to identify emerging trends and to identify best practices that can then be adopted and employed throughout those organizations that participate and that we work with. So what are the barriers? I think Dr. McClellan spoke to those, but what we see, the data shows that everybody knows that there are a variety and wide variation in the scope of practice laws across the states, which can be very confusing to consumers, to physicians, to even advanced practice nurses and other clinicians. And so what the data does is elucidates that variation, identifies those that are able to go to top of license, and then allows others to use the data to make those movements in either healthcare policy or in practice acts. So in Illinois, the data was actually used. There was a proposal to limit the scope of practice for CRNAs and for physician's assistants, and the data was then used to show that that would have tremendous impact on providers across Illinois, and that bill was never heard. It never went to committee for a vote. Also, what we see is a barrier at the organizational or the institutional level. So medical staff bylaws, scope of practice acts can change, but for those that are providing within healthcare organizations, hospitals, they have to be privileged and credentialed. What we oftentimes see is bylaws, because of the confusion in the state practice acts, can become very limiting themselves, and then the credentialing and privileging practices. So what the data does, again, is elucidates what is going on in an organization, as well as then you can look at what APRNs are allowed to do within a healthcare system or across the state. And that then has allowed organizations to really change their bylaws and to really open up their credentialing and privileging practices.
Great, great. And we'll hear more from you later about what some of those results have been. So, Kevin, as we know, Target has a lot of retail clinics or clinics within the stores, and you're hoping to expand them even more. Tell us about how your organization is using APRNs now, what you see as the barriers, and what you'd like to see changed.
Sure. First of all, thank you to AARP. We're thrilled to have this forum to speak at. And wow, Mark McClellan's got a lot of great information, huh? So Target's role in the retail space, we have retail pharmacies and retail clinics, and I think there's some parallel discussions there around top of license practice. But for Target, our approach has always been understanding what it is that the guest that shops Target, what it is they're looking for, and how it is we can help meet those needs. And if we start with that constituency, which is really building around a consumer, around a patient, whatever we want to call the individual who has a need for health, it makes a lot of sense for us to think about a retail setting where people are already visiting that location, meeting their everyday needs, making the choices that really are the determinants for their overall health over the course of time, as opposed to the 1 or 2 visits they might have in a physician's office. We've found that the nursing staff that we have in place in our retail clinics can help meet that need from not only the convenience and accessibility, but the experience standpoint. And at Target, that's another thing that's so important to us, is the experience. And hopefully those of you that have shopped our stores see that experience is important. We find that with our nursing staff and that convenience and accessibility, our clinics rank #1 in the store for all departments on guest experience. So we're really excited about the role of nurses and advancing the role of nurses in that space. Trish alluded to this, and Mark alluded to it. I'm sure you're going to hear it from others as well, is that there's a lot of regulatory barriers that get in the way of us being able to do what feels like the right thing to meet the needs of the consumer. Each of you are a consumer. You have healthcare needs, and I'm guessing, we won't ask for a show of hands, but I'm guessing every single one of you has asked the question, why do I have to, when it comes to reaching some sort of health need or achieving some sort of health need? And we see barriers everywhere from payment in some of the, Medicaid is one area that we've seen some barriers that are likely legacy law, but think about managed care enrollment and where there's a medical home. Now a location that's a much more affordable and convenient location for a mother or father with a young child that needs to get to their minimum wage job to help make ends meet, they still have to go through the system of seeing their physician who may not be available that day because we can't be in that managed care network, or if we are, it requires a physician referral to see us. And how much sense does that make? I mean, whose needs are being met by that? Now, that's not in every state. Every state chooses how they want to do this and how they want to administer Medicaid. But that's a real barrier that exists, along with the scope of practice that's been mentioned, and then I think what we're going to see emerging more and more is the virtual care telemedicine space, which has some pretty tight restrictions on the role of nurses.
Great. And again, we will delve more deeply into those barriers shortly. So Andrew, you are heading the CVS Minute Clinics, obviously potential competitor perhaps to Target, but you're sitting next to each other, so I know you're going to play nice. You're going to play nice here. Tell us again about how you're using them in the Minute Clinics, APRNs, the barriers, and what you'd like to see changed.
Yes, and thank you very much. And again, I also want to thank AARP and the Center for Nursing Advancement for inviting us this morning. These are exciting times for us at CVS Health, and we certainly think nurse practitioners play a very central role in the role that we see ourselves playing in healthcare going forward. Our company is made up of 7,500 pharmacies around the country, one of the largest pharmacy benefit management firms that manages benefits for 65 million Americans, and of course our growing Minute Clinic chain. And we're very proud that we've recently, as a couple of weeks ago, removed all cigarettes and tobacco products from our stores. And I must say, to complement that, we have launched a national smoking cessation campaign in which both our nurse practitioners and pharmacists play a very vital role in helping people to stop smoking and help people on their path to better health. Now, as we look out at the environment, what we see is an aging population with an epidemic of chronic disease, particularly diabetes. And we also see a shortage of primary care physicians, 45,000 physicians short in 2020. You put the background of the Affordable Care Act and the infusion of millions of Americans now who have coverage, the simple fact is we will not and do not have enough primary care physicians to meet all of those needs. And that's where I think the important role that Minute Clinic plays in helping to complement and support the patient-centered medical home is so vital. And I'll think about it in terms of access, quality, and cost, the issues that were brought up earlier. We see patients 7 days a week on a walk-in basis, evenings, weekends, holidays, providing the access that so many Americans need to care. We see many patients, half in many states, that do not have a primary care physician. We give them lists of physicians for follow-up, but in that way we're playing a vital role in providing access to care. And frankly, the alternative sites of care for many of the conditions we treat are far more expensive. A RAND-sponsored study showed our care was 40 to 80% less expensive than emergency rooms or urgent care sites, even physician's office. So at this moment in our national discourse on healthcare, having an easily accessible site of care that provides evidence-based solutions for patients that's low cost is really vital. The other important point, about half our patients are seen on evenings and weekends, when the only alternative is often a much more expensive site of care. Now, we do not see ourselves replacing the primary care physician. Quite the contrary. We see ourselves complementing and supporting the patient-centered medical home in a setting when there's a limited number of providers and burgeoning demand throughout the country. And we've done that by affiliating with major health systems around the country. In fact, 41 major health systems and many more to be announced shortly. Places like the Cleveland Clinic and UCLA, Sharp Healthcare, many others around the country that are affiliating with us to integrate electronic records with them, to work together on chronic disease programs, and to have their medical directors serve as physician collaborators for our providers. We use the same model around the country of physician collaboration. We believe a team of providers, as Mark articulated, is the best way to provide the right level of care at the right location and allow people to practice at the top of their license. So going forward, I would say we see four major areas of focus. One is expanding our footprint. So we operate today 925 clinics in 29 states and the District of Columbia. We're in the midst of adding 150 clinics this year and expect to get to 1,500 clinics in 2017. We operate over half the retail clinics in the United States, and we expect that those numbers to continue to increase. We've been adding to our scope of services along the lines that were outlined earlier, and particularly in chronic disease areas where we can monitor patients, check a blood pressure, a blood sugar, and send that information back to their physician, as well as wellness services, helping people to lose weight or stop smoking, a variety of roles that nurse practitioners can do a superb job in terms of coaching and counseling and educating patients. We continue to make affiliations with health systems so that our notes go into their electronic record and we have access to their records at our clinics. So we have a larger medical home, if you will, a medical neighborhood enabled by virtual technology that again can help us to lower costs and provide outstanding access. And then finally, through technology. So we've launched a pilot of telehealth in California and Texas that I think makes best use of our providers' capabilities and technology to lower costs and increase access. And in addition, are rolling out the Epic electronic record, again, to connect with providers around the country that are on that widely used system. I think in terms of barriers, there are a few critical areas I would describe. First, my colleague mentions the great heterogeneity in rules and regulations that guide practice. We use the same collaborative model between nurse practitioners and consulting physicians in every state, regardless of whether it's required or not, because we think that's the best model of care for patients. But as a national company in 29 states, that variability is a challenge. I'd say the second thing is a workforce challenge. We've been able to staff. Our model is very desired by many of our excellent nurse practitioners. But going forward, we need to have well-trained, large numbers of nurse practitioners in order to support the needs that I outlined. We have internship programs, we have a fellowship program, we do research, we provide CMEs. So we're very much engaged on the academic side. We have relationships with 100 nursing schools in order to make sure that there's a pipeline of well-trained nurse practitioners for the future. Now is the time for us to address those concerns for the future and to establish that pipeline so that we're not behind the 8 ball. And then lastly, I'd just say, as delivery systems and models of care evolve in an innovative direction, we have to make sure that regulations and payer requirements keep up with those innovations. And I think telehealth is going to be a challenge in this regard, to be able to provide those services in a way that is widely available to patients to help lower cost and increase access. Again, I thank you for the invitation today and look forward to my colleagues' comments.
Terrific. Thank you so much. So Randy Krakauer, now to you. And again, how you're using registered nurses and APRNs, what the barriers are, what you'd like to see changed.
Right. Thank you very much. The delivery of health care has previously been compared to building a house without a general contractor. Absence coordination, we see problems associated with quality, efficiency, and high cost that is not equated with better quality results. There are various ways one might consider addressing this. What we have been doing for some years is building a care management infrastructure, principally with nurses, to identify and engage and impact members principally with chronic illnesses and advanced illness, with the goal of improving the situation for our benefit and for our members' benefits. And in fact, this has been quite successful, and particularly in the Medicare space, I would say the role of these nurse care managers is crucial. One particularly dramatic example is in the area of advanced illness or end of life. Now, this is a program which we call compassionate care, of care management for persons in end-of-life situations, which was begun some years ago as a chairman's initiative under our then chairman, Dr. Jack Rowe. These are specially trained nurses, principally nurses, who have had training and experience in care management in this in particularly vulnerable population. We have seen extraordinary results in this population. We have seen, for example, an 82% reduction in acute care and an extraordinarily high level of satisfaction for the particularly for the 1% of our Medicare population that we engage in this program. And when I say satisfaction, satisfaction is hardly even the word for it. It's more gratitude than satisfaction. And others have followed, and particularly several provider groups have also reported comparable results. Demonstration that this is possible, and I would say, creates the imperative that it become standard of care, that it in fact be done. We have, we have shown a way to do it, but with extensive use of nurses and APNs. Considering the need for this, and that is, when you see impact of this magnitude, it speaks to more than a good program. It speaks to a need that is desperately there and so often not fulfilled. Frankly, it's hard to imagine a way to fill this desperate need without extensive use of nurses in this area. I don't see any really good alternative. So here is one area in particular that I would say is the greatest extant opportunity, particularly in the Medicare population, for a dramatic impact at the intersection of quality and course, for which extensive use of nurses and advanced practice nurses will be required. We've also been building what we call provider collaboration enterprises, which is a form of ACOs, and we've been doing this for about 7 years, particularly in the Medicare Advantage space, and we have about 150 of these. In which we're doing similar things to ACOs. We're looking to realign incentives, but we also share data, and we also, in its most advanced form, will provide embedded case nurses to work directly with the physicians and with their staffs. And we find that when we do this and we get good clinical engagement, this is also when we get the greatest potential impact. And we have likewise reported and published some of these. So where we have a good primary care base and we have embedded nurse case managers and good clinical engagement, there are places where we've seen as much as a 50% reduction in avoidable admissions. We have several good collaborations in which this is occurring, in which this type of collaboration is dependent on nurses that are working with the staff to accomplish better care management and better care coordination. And we've also facilitated work to help some of these groups expand on their own use of their own nurses, and particularly their own nurse practitioners or advanced practice nurses. Likewise, we have collaborated with Mary Naylor at the University of Pennsylvania several years ago in launching a transitional care program involving advanced practice nurse visits to homes of persons, particularly in the Medicare population, that have been discharged, that are considered at risk for inadequate care management. And we've also published this, and we've also seen very favorable results here, which has become a lesson in how to build good transitional care programs, which we are currently expanding on. And we're also working to combine significant elements of our compassionate care advanced illness program with transitional care in several areas. And we think there is a considerable opportunity, has been realized, and considerable opportunity yet to be realized in this area. Finally, a good deal of the needs associated with particularly an elder population is with chronic illness, or more commonly multiple chronic illnesses. And there is need for better care management and care coordination in this population than we see now. Part of the reason is because of the shortage of primary care in general, and part is the need to address this population on a long-term basis. And we likewise see opportunity here for APRNs and nurses to engage these populations long-term, for long-term management of risk factors and chronic illnesses or multiple chronic illnesses, get away from the one-year impact focus, and really look to have an impact in a time frame that is more reasonably to be expected in the case of some of the chronic illnesses that we deal with. We are going to, these all sound like they're separate enterprises, but actually they're not. They all come together into a single unified strategy of our ability to better address and manage chronic illness, advanced illness, and risk factors to achieve what I would say is the goal of good impact at the intersection of quality and cost. We think this is possible. We think it's doable. To a good extent, we believe it's already been demonstrated that it can be done, should be done, and must be done. We likewise feel that the best option, and in some cases perhaps even our only option, is more extensive use of nurses and use of nurses working to the top of their abilities and the top of their license.
Thanks very much. And we'll hear some more about that in just a moment. So now we've got Aetna and Cigna sitting next to each other now too, so competitors as well. But Mary, tell us.
It's all good. It's all good.
Tell us again from your perspective what Cigna is doing to make use of RNs, APRNs, barriers that you're encountering, and what you want to see changed.
Sure. Thank you, Susan. So at Cigna, we use registered nurses and nurse practitioners in a variety of different ways to support our business model and our customers. Some of those ways are that we use nurse practitioners as healthcare providers at our Healthy Life Centers. Those are actually on-site clinics that are located at an employer's place of work, many times in rural or underserved areas as well. We have nurse practitioners that are in leadership positions. So these nurse practitioners are overseeing Healthy Life Centers or clinical operations at Cigna. We have registered nurses and nurse practitioners that serve as telephonic case managers or on-site coaches. And then, of course, we have nurse practitioners that are part of Cigna's provider network who are rendering services, submitting claims, and getting reimbursed for the services that they provide. And in terms of the value that the registered nurses and nurse practitioners bring Cigna and our customers, I mean, the list is long, actually. For me, if I were to pick a couple of things at the top of the list, I would say that they most certainly support the triple aim, affordability and satisfaction and accessibility. They are, deployed in places, as I mentioned, that are inner city or rural areas that are underserved. A lot of times there aren't even physicians in these areas, but the nurse practitioners are out there serving that particular community and are pretty much the only means of health care for a lot of folks in those geographies. And in addition, as you all know, nurse practitioners and registered nurses generally spend an extended period of time when they're evaluating and educating patients. And that extended period of time, they get to understand the social and physical impacts of the chronic condition. And that extra time spent is really an investment that helps facilitate improved health outcomes, adherence to treatment plans, lower complication rates, and just basically a general overall improved well-being or quality of life for patients. In terms of the challenges, I don't think the challenges are new to anybody in this room, and some of them were mentioned by my colleagues as well. There certainly is a shortage of primary care physicians and has been for a long time. They're not graduating from medical school in the numbers that they used to. There are more folks entering the healthcare system because of healthcare reform. I believe a Deloitte and Touche study was done back in 2012 that showed primary care physicians were retiring at least a year or two earlier than they had originally planned on retiring. And then, of course, the population is aging. And with the aging of the population, we see an increase in disease burden and chronic and complex conditions, which requires even more providers to address those issues. And so in terms of barriers and challenges, I think there's certainly a lot of things that we can do, and we'll be talking about a lot of those today. But I think one of the things that we also need to do is to create an environment where we can influence and sort of channel nurses into advanced practice degrees to help serve the gap and close some of the issues that we, address some of the issues that we're seeing and talking about today.
Great. Well, thanks to all of you, and we've heard in just almost all of these instances how much use is already being made of registered nurses and advanced practice nurses, and how much more, I mean, really that was coming through in all of your remarks, the potential to continue to move down this road and expand their role is enormous. But you've all also identified barriers in common. Almost all of you brought up scope of practice and the different rules and regulations in place in the various states. And as we know, this remains a real problem. Many of you mentioned payment, and Kevin, you in particular mentioned the rules in place in some states where a patient can't even get care from a retail clinic without getting a Medicaid patient, without getting a referral first from a physician, and what sense that makes in this day and age. You've all mentioned other restrictions not bearing specifically only on advanced practice nurses or nurses, which is restrictions that militate against use of telehealth and other forms of delivering health care more efficiently. And you've all talked about the primary care shortage, whether it's embodied in the shortage of primary care physicians or primary care in general, and the need really to stimulate the pipeline, particularly the pipeline that is producing not just registered nurses, but having them move from registered nurses onto advanced practice registered nurses. So let's drill down a bit more on those issues if we could, and let's start with scope of practice. Now, Trish, you mentioned one episode in Illinois where people were successful in blocking a provision that didn't bear specifically on RNs or APRNs, but rather PAs and certified and APRNs also. Okay,
yes,
okay, they were part of the mix.
Yes.
Okay, so let's talk about that for just a moment. What were the arguments that were persuasive in blocking that measure, and how do you build on those arguments as we tackle these issues in other states?
I think one is to actually have the data, what the impact would be. So in this case, it was going to limit the use of fluoroscopy, limit the use of conscious sedation to only physicians. We were able to pull the data to show that that would have had a tremendous impact. Multiple hospitals across the state, multiple providers across the state, where CRNAs, nurse practitioners, and physician's assistants were doing that. Should that have limited the scope, it would have really then, access issues would have come up, timeliness issues, quality of care issues. So I think it's the data. We have another organization, very large organization, very large ACO contracts. And their CEO and CFO took a look across their system, and they realized they had about 300 advanced practice nurses. But the variation in how they were utilized, what their scope was, again, this is within one state, they said this doesn't make sense from an economic perspective, so let's make sure that we work with our medical staffs, we work with our providers, and we optimize. And so they're working on changing their models of care so APNs throughout the entire system can work to top of license in all their credentials and their privilege. Again, we see that. We had another organization that was looking at did they have enough anesthetist coverage? And they had a variety of CRNAs in multiple hospitals. And what they did is they took a look at across the system, the CRNAs were not allowed to practice to top of license. So rather than have to go hire a whole nother anesthesia group, they actually then said, let's optimize those that we have in place. It's a much more economic model, and it's also a team-based model where every provider on the team is then working to their top of license. So all data-driven.
Okay. And particularly, I want to hear this from others of you as well, you're often driving this data against the interest or the perceived interests of many physicians. Now, not all physicians. Many physicians are working hand in hand with nurses and teams, but there still are a lot of physician groups that are trying to get these scope of practice laws passed or remain intact. So love to hear others of you address how you take on that force as well. Kevin, let's go to you on this issue. As Target presumably tackles this issue in its various states, what do you find is persuasive in making the argument that scope of practice should be expanded?
Well, you know, we've been fortunate that a lot of these laws have been evolving and changing as we've started expanding our clinics. So we haven't run into states where it's become a barrier for us to open our clinics. And I think, you know, it was mentioned earlier that we have a standard of approach regardless of the regulatory environment. We have relationships with physician groups, and we want to make sure we develop an environment where there's integrated care, where there's a primary care group that we can be affiliated with. We have physicians that can be available for mentoring, consultation, professional development in each of our markets. What's interesting to me is that there's an administrative burden that varies state by state that hasn't been demonstrated to have any impact whatsoever on quality and outcomes. And many of the states have requirements on doing chart reviews. So they require a physician to sign an agreement that allows a nurse practitioner, advanced practice nurse, to practice within a certain scope. Then they have to review a certain number of those charts. There's some requirements for being on site at the practice location. There's some requirements for routine visits, and some of those require even face-to-face visits.
All under the realm of supervision.
Under the, yes, supervision. And none of these, at least as far as what I'm aware of or have come across, have been demonstrated to impact the quality of care or the experience of care or the cost of care. So the things that we all talk about wanting to achieve, we have these regulatory requirements in place that in no way serve the needs of the outcomes that we're all trying to achieve. And I would say across the retail clinic industry, I think there's consensus that we want to be part of the healthcare ecosystem. We want to be partners. We see that we play a key role, and that advanced practice nurses can provide a broader footprint or a bigger front door for the system to take care of a lot of the things that, frankly, the physician groups shouldn't be arguing about, I don't think. I sat on a panel here a few months ago, and Susan Reinhard was on the stage as well, and Frank Serra from the University of Minnesota, who's held about every post you can imagine within the medical school and the university physician group. He said it very well. He said physicians are trained to deal with broad differential diagnosis, which means ambiguous things that require you to think across a broad range of possibilities, and then complexity of care. And anything else we really shouldn't be arguing about. And he said it very succinctly. And so we think about the role of an advanced practice nurse and the workforce issue. It shouldn't be physicians against nurses. We've got an aging population, an increasing disease burden, physicians who are going to be retiring at a rate that we haven't seen in the past. And in 2012, the numbers that I saw was just shy of 2,000 of the medical school graduates, which is 12% of medical school graduates, choosing primary care as a profession. And that was a net increase of 29. I can't remember if it went from 11 to 12 or 12 to 13, but a net increase of 29 actual medical student graduates that were choosing primary care. And now you look at advanced practice nurses, and what you see on that side is that it was somewhere in the neighborhood of like 11,700 nurse practitioner graduates, and it's 84% of those graduates choosing primary care. So the reality is we have a workforce evolving that is prepared to take care of a population of patients in this country, and we just haven't figured out how to align our system and align our financial incentives. Mark alluded to this as well. We work in, and I'm sure my colleague, they work with several organizations that have at-risk contracts, ACOs, shared savings. And there are still some opportunities for us to figure out how to align financial incentives within systems and across systems to best leverage the workforce that we currently have. And I think that's our biggest opportunity collectively, is to figure that out.
Great. And we're going to come back to that payment piece in a bit. But staying on scope of practice for a moment, Andrew, how is CVS approaching this across the country?
Yeah, I would say just our model is really to focus on collaboration. We don't think patients just get sick on a Sunday afternoon when they come to see us for an ear infection. it's got to be seen in the context of the larger environment of healthcare they receive. And as Mark described earlier, it's a team-based approach that'll allow for the best use of resources, really the best care for the patient. Our model is to have physician collaboration with all of our nurse practitioners. Those collaborations are to have educational sessions, chart review, and also to do telephonic backup when there's questions on particularly complicated cases. We do that everywhere, and we think that's the right model. And in fact, we collaborate with 40 health systems around the country where we have integrated electronic records and participate in chronic disease programs. I do think there are signs that these issues are moving in the right direction. I think Massachusetts is a good example. As you know, Massachusetts first did access in their set of reforms. They provided regulation laws that would allow for access broadly. And then secondly, now more recently has come back to do cost control or payment reform in a way that would allow for cost control. And in Massachusetts, as part of a broad set of cost control measures enacted last year, they actually expanded the scope of practice at our retail clinics and for our nurse practitioners to the full scope of a nurse practitioner's capabilities. I think that's a good example. Massachusetts has the highest number of PCPs in the country per capita. But even in Massachusetts, there are significant shortages and long waits for primary care visits. And I think those changes in regulations suggest the important role that our providers play. But I would emphasize, from our point of view, it's not a competition. We have an overwhelming demand right now of patients, and we need to work together as a team, everybody fulfilling their appropriate role in order to take best care of them at the lowest overall cost. We're supportive of the medical home. We see a lot of medically homeless people. And so our role is to see them, evaluate them, and get them hooked up with a patient-centered medical home for continuity and follow-up. And that requires that we all play kind of a team-based approach to the care of patients, and that's really what we hope proceeds.
But for every Massachusetts, there's a Texas where physicians are battling long and hard to retain, to limit scope of practice. So how do you act in those
Well,
arenas?
I think even if you look at Texas, they have recently changed their regulations to make care more accessible, again, with collaboration between nurse practitioners and physicians. And I think that that is the kind of change that, you know, we certainly are supportive of. Look, the reality is it comes down to one interaction between nurse practitioner and a patient. And if we can provide a model of care that allows for the relatively retail clinic-oriented care to be provided, but then there to be a larger context for more complicated things, that's the best model, really, we think, for patients.
Great. So Randy, let me ask you that same question about scope of practice. How does that affect, as a national insurer, are you limited in how you can use the model, as you described earlier, compassionate care in some states versus others, by virtue of scope of practice?
Well, in some states, scope of practice clearly will limit what we can do in collaboration with, for example, nurse practitioners or advanced practice nurses. In terms of providing case management, we don't see as much limitation in this program. There's not a whole lot of limitation in terms of what a nurse case manager can do. And these case managers are going to touch base with the physicians or the physician's office to ascertain that this is an appropriate case for engagement. This person really, does have advanced illness and can benefit from it.
But in terms of in the case of case management, they're not providing care, correct?
In this particular instance, they're not providing care, so we're really not running into scope of practice limitations. And some of these limitations were written. We are running into this as barriers in some of our provider collaboration enterprises, where where there is more than that their advanced practice nurses or nurse practitioners could do. And we're working with some of our provider partners in this area. Some of these limitations are based on regulations that are outmoded, and sometimes they're based on unfortunate conflicts, professional conflicts, where there should be collaboration rather than conflict.
And Mary?
So
Cigna follows a reimbursement policy for nurse practitioners that is, very much aligned with, of course, state regs. But I do want to mention one thing that I think insurance companies or health plans find a little perplexing around state regs, and that can even be for telephonic case managers. There are some regulations out there that can be interpreted very differently by different agencies or entities about whether or not you require a nursing license in every state of the country. And so, for example, with Aetna and Cigna, we're national insurance companies. Our members are in every state across the country. Our case managers and nurse practitioners are educating telephonically, online, via web. And the question out there that really does need, I think, a little bit more clarity is, if I wanted to talk to a member in Florida or California or Texas, do I actually need a license in that state to have a conversation with them about improving their health? And I think there are a lot of different opinions and out there on that topic, but it is something that I think requires a more careful look, because that is really a barrier. As a health plan, when you're trying to talk to a lot of different patients across, any given day or period of time, those kinds of regulations can be, one, cumbersome for the health plan and the member, two, add to the cost of health care, and three, just add a lot of complexity to just being able to, educate people about how to improve their health in general.
As we all know, this state-by-state regulation of health care goes back to the founding of our republic and the fact that any powers not specifically dedicated to the federal government were deemed to lie with the states. And so welcome to the 21st century, where the states essentially still take a lot of the lead on regulation of health care. Is it time to have a move toward a more national approach to scope of practice type issues and some of those additional regulatory issues like the one you just mentioned?
I don't know that I know the answer to that, because it's a very complex answer, and I think there's not a right or wrong way. I think there's probably a lot of different solutions out there that would work. I think what I guess in my personal opinion, what might be most effective is for insurers to sort of join forces and to adopt a position, a universal position, whatever that might be, and to lobby for that to take place. And I think when we join forces, Cigna's, Aetna's, United Healthcare, and the Blues, other organizations, you've got some muscle and you can influence decision making. But I think the way it stands today is there's a lot of ambiguity and additional complexity that's creating unnecessary cost in healthcare.
But if you join forces, but you're joining forces to attack all of these on a state-by-state basis, is that a recipe for success? Andrew and Kevin, I'd be interested in your views on that also.
I mean, I think that currently, as you describe, each state has their own regulations, and that does create a challenge. I think the part that was mentioned earlier, I think that would be important, is we should really be evidence-based and driven by how we decide on these things in the long run, even within the states. That is to say, if there's evidence that a certain model provides better outcomes, then that should, sort of drive our decision-making about it. And I hope that as we increasingly think about evidence-based care going forward, that'll become more of the basic principles around how we think about these kinds of regulations. I know the care we deliver is evidence-based. We try to use evidence-based practice throughout at Minute Clinic and practice in that manner. And I think these issues that relate to regulation could also benefit, from that approach.
Is that a call then for more research to be done? Do you all have a responsibility to be funding more research that can produce this evidence to take back to lawmakers and others?
It's an interesting question, and I don't know the answer to that either. I think it does come back to if there's right now we don't have the way. No one has the answer on what's the right solution. I think we all know generally that there's a direction we need to go, which is more alignment, less fragmentation or disparity between the requirements state to state, and it really should come down to where there is evidence. it would be great if there was somebody that, you know, and Target, we don't do research necessarily. We do have a lot of data internally. But for the right organization, it would be a great research project. And I think the data would be very beneficial. One of the things that I see, you know, as a physician is, while there's differences for myself, and, you know, I don't know, you know, about your licensing, but when I go state to state, there's nuanced differences. But the reality is, if I wanted to practice medicine in every one of those states, it wouldn't impact what I do with every individual patient. And so I could confidently go from state to state and practice the same scope of what I do. And I see that now in nursing, that you take any city that is along the border between states, and you could drive 1 mile west, east, north, south, and suddenly you can't provide the care that you know that you're capable of providing. And to me, that it doesn't seem right. You know, it seems like there's got to be a better way to do this, and likely if we can get evidence, then at least there's a place to start the conversation from.
Well, I think I heard an offer to supply data for someone who wants to do research on how this plays out at Target and potentially also CVS MinuteClinic, so you might want to tweet that out to your research-oriented friends so that they know that that offer is on the table. All right, let's talk about payment here. Now, Kevin, you mentioned the issue of Medicaid payment and the Medicaid regulations that won't allow somebody to go unless they have a referral. You also, most of you have talked about these alternative arrangements that are now forming around patient-centered medical home, ACOs, ACO-like arrangements. What else needs to be done to change payment, and that is also militating against the full use, full deployment of advanced practice registered nurses? We know this is still an issue in the Medicare program. Randy?
Well, anyone who works in medical strategy and tries to implement anything you might consider innovation is likely to run into regulatory barriers. And not just in the area of scope of practice, but in other areas too. I mean, we mentioned, for example, our compassionate care program, and you know, one of the barriers that we ran into was the Medicare hospice benefit. We've demonstrated that it should be liberalized, that it can be liberalized. We advocated to be liberalized. This is a federal regulation; it's not a state regulation, and we've been working towards finding a way to liberalize that benefit for several years. And it hasn't happened yet. There are regulations, there are regulations that are outdated, and need to be revised. And there are some regulations that are written perhaps as a result of conflicts that need to be resolved. In the context of scope of practice of nursing, I think the best approach, and I'm not going to say whether we should do a federal, abandon federalism and do this at a national level. I'm not going to address that question. But what I would say is that we've clearly demonstrated that there is a shortage of primary care. This shortage of primary care is getting worse. Physicians need an adequate amount of primary care in order to do their jobs. It's not just the system, the patients, or anyone else, but it is in the best interest of physicians that there be an adequate amount of primary care out there. There is not just a shortage of primary care, there is a shortage of potential solutions to the problem. So I think the real opportunity here is to engage physicians, to engage medical societies, to engage the physician community, an awful large portion of which is in agreement that this is our best route, and we should work together to achieve this. Does that answer your question?
I think another thing too is what we're starting to see is many healthcare systems to actually work with their managed care contracts to say whatever the service is, it doesn't matter who provides it, this is the payment. And that really takes all the complexity out. And so, again, where it will take time to make the Medicare changes, we're starting to see as people get into large shared risk ACO programs, bundled payments, it doesn't matter the provider as long as the outcome is there and the patient is receiving the service. So again, when it comes to payment, the payment should be for the service or the outcome as opposed to the provider. And I think if we can begin that kind of dialogue, And we're starting to see some large organizations work with the large managed care or insurance organizations that their contracts actually state that. Doesn't matter, whoever the provider is, we get this payment.
So Mark McClellan mentioned proposals to enable advanced practice registered nurses and others to bill the Medicare program directly for their services. And his view was that's more fee-for-service. We really ought to be going down a different road toward more global payment, et cetera, et cetera. I'm wondering, Mary, do you all have a position on that?
I don't know that we have a firm position on that. I think that's constantly something that we're looking at, right? I do see that the direction is obviously to pay for outcomes. And I think, as Mark had mentioned in his opening remarks, it's very much a care team approach. And when you're paying for outcomes, you know, most of the offices have multidisciplinary care teams there, so you're paying for the health improvement and the outcome as opposed to fee-for-service. Today, of course, there's still very much a fee-for-service arrangement in a transition where we're moving to paying for outcomes, and I think that's the next step, is paying for outcomes for care teams. So I think that's the evolution that will probably occur.
I'd say a little on the payment front, just that you know, our prices are transparent and low. And in a world where we still have some uninsured people, but perhaps an even bigger and growing area is a large number of people who have coverage but actually have high deductible plans, the cost of care is very apparent, and I suspect that those numbers will grow over time, certainly with the Affordable Care Act. So being able to know how much care is going to cost and having a good sense that this is a good value from the patient's perspective is important. We do research on data we collect, and we've published on not just that the cost of care is lower, and I mentioned the RAND-sponsored study showing our care was 40 to 80% less expensive, but we have a study that showed that total healthcare costs for matched patients that used our clinics compared to non-users had 8% lower total healthcare costs. So I think that there is an opportunity to engage with our nurse practitioners in various ways that can help to hold down costs, and hopefully that'll lead to broader and wider acceptance from the you know, from the payer front. There is heterogeneity today in what payers cover, even among private payers, and I think that there could be some greater broadening of those coverages based on really the evidence showing that nurse practitioners provide very high value services that not only directly but also help prevent other bigger costs that would occur given the shortage of access that we face.
And as we transition from payment for volume to payment for outcomes, that is going to facilitate a need for, or perhaps a demand for, more extensive primary care, more extensive longitudinal care management, attention to issues such as education and adherence, for example, and that is itself going to create a need for, a demand for, you know, more advanced practice nurses or nurse practitioners who can fill these roles and assume that type of responsibility on a large scale.
So we're going to open this up now to questions and comments and perhaps short speeches masquerading as questions from those of you in the audience. And fortunately, we've had one that has already come in, and this may have been a question of interpreting correctly or incorrectly something you said, Andrew, but let me ask it, and you can clarify. From your comments, this questioner writes, it appears that you are adding barriers and administrative burdens, even in states where APRN laws do not require supervision. Aren't you taking us backwards? Do you want to comment on that?
We do not, in those states that don't require it, we don't require collaborative practice agreements, for example. But we do think that a model of care that allows for some broader network to take the patient when more complicated conditions arise is really essential. We have a well-defined narrow scope of service, and when a patient falls outside that scope, we need to have a way to take care of them. And often they don't have a primary care doctor, so it's that much more important that we have a place to send them in order to you know, provide for that care. And that's our model, and it allows for us to do the parts of the role that we can do, and also to have backup for more complicated situations.
Okay. Hopefully that cleared things up. Okay, terrific, great. So we'll take some questions on index cards here. How will the new CMS payment for chronic care management services affect the financing barrier to involving APNs in care delivery to the top of their license? Does anybody want to take that on? Yep.
It has the potential to facilitate the greater or more extensive use of nurses or APNs in chronic care management. It creates a financing mechanism to help fund this. So it's a step in the right direction. There's still going to be gaps and there's still going to be barriers. It's not going to solve the problem, and we can probably find more extensive approaches to the problem. But I would say that this should be helpful.
Okay. Anybody else want to comment on that? Okay. All right. This questioner writes, almost everybody on the panel has eloquently spoken about the importance of APRNs in meeting the triple aim goals. I'd like to know what funding opportunities are there for APRNs? And secondly, is it necessary for them to have a terminal degree? Why is there a need for, say, doctors of nursing practices? Is an FNP or a AG, I'm having trouble with the handwriting, an alternative degree enough? Do you all, what are your requirements? Do you have to have a doctor of nursing practice to get anywhere in the CVS?
It's not a requirement, but many of our providers are pursuing that degree. We're supportive of it. We sponsor research that they may do, and sometimes using our data in order to achieve that degree. We have continuing education opportunities. We're actually an accredited CME provider, so we very much believe in helping to advance the careers of the nurse practitioners that work for us. And beyond that, a topic that we didn't cover today but is in the Institute of Medicine report is we also provide a lot of leadership opportunities for advanced practice nurses, and we think that's very important. We have over 100 nurse practitioners that serve in leadership opportunities in our company, and I think as we look ahead, it's going to be very important that nurse leaders have opportunities to grow and develop their careers. So I think that's an essential element.
Do you want to speak to that as well?
Yeah, I mean, I'll say similar comments in that the professional development of a workforce, and in this case advanced practice nurses for us, is critical. And so we're seeing more and more individuals that are choosing to pursue a doctorate in nursing. We're very supportive of that. We have programs in place to support their research in our environment and lead them to publications, working with the affiliated schools we have. We start that, similar to some of our other colleagues in the market, with students of nursing who are looking for clinical rotation sites. And that accomplishes a couple of things. Number one, it's providing a site for a student, but also it's creating a professional development opportunity and a leadership opportunity for our team. And that leadership opportunity then has line of sight all the way up into the headquarters team. So it's really about developing a workforce and advancing the opportunities for leadership roles in that nursing profession, as well as broadening their education for those that are choosing to stay in a direct patient care role for us.
Let's turn over to our payer friends. What are both of you doing to...
Well, I would say I certainly agree with Andy and Kevin's comments. And at Cigna today, I know of several nurse practitioners that are actually pursuing their doctor degree. It is not a requirement at Cigna, but that is the trend, that is the direction that we see the nurse practitioners, at least at Cigna, moving into.
Likewise, yeah, we have. It's not a requirement, but we certainly support those who want to do this and or who want to do this as a way to further their own professional careers, and we will help out in any way we can.
A question that came in from Twitter. Some areas of the country do not have many retail clinics. Is that because their presence is limited by a state scope of practice law, or are other factors at work? Andy, you want to start?
Yeah, I would say, well, for us, there are some areas of the country where CVS doesn't have pharmacies, so that is a basic. That has nothing to do with the first question. There are some states where the requirements are more challenging, and we certainly take that into consideration when we decide what states to enter. I think the good news is most states are moving in a direction that allows for greater freedoms in this area, and has been increasingly accommodating. But those are really the major factors. We're not in some states, and then there are some states where the regulations are make the style and model of practice we have more difficult.
And similar for for us, Target's footprint, we're in 48 states with just shy of 1,700 stores in the U.S. And that's where we have to start with, is where our footprint is. And so we've started our approach by identifying which markets make sense from a Target guest perspective and where we have stores located. And then secondly, that's migrating pretty quickly into this whole partnership discussion that we've been having, is there's a lot of interest that's starting to develop with these companies, these healthcare institutions that have at-risk contracts, and they're trying to figure out how to take that next step, and they look to a Target clinic, Target pharmacy as a retail partner that could expand their footprint and help them extend their reach and lower their costs. So there's a couple different ways that we would approach it, and I would say third and also very important is what type of regulatory burden would you encounter by entering that state?
All right, we're going to ask one more question that came in from the audience, and then we'll move to wrap up. And Trish, I'm going to aim this one at you. What can insurers do to motivate hospitals to modify their bylaws to allow APRNs to practice to the full extent of their training, certification, and licensure? You mentioned this big system in Illinois, may have been Advocate, it sounded like, potentially, that was that took this on and looked at how they were using these people differently within their system.
I think as organizations go into more shared risk and the payment model is based on outcomes, organizations are taking a look at how do we best optimize the team. So again, another system. They had access issues in primary care. They hired 75 APRNs to open up their access in primary care. Other organizations, we see that we're embedding psychiatric nurse practitioners into primary care settings, into geriatric clinics, into HIV clinics, because we're better than working with those at-risk populations to increase compliance, increase treatment planning, immediate access, refills of prescriptions, which all lead to better quality, but also immediate access to care. We have organizations where they're looking, again, in at-risk or bundled payments, they're using nurse practitioners to run diabetic clinics or congestive health failure clinics where you have the high readmission potential, which is going to be a very ineffective cost of care. And so, again, I think the insurers, as more and more organizations are going into shared risk or bundled payments, it's really looking at the whole team, and that's forcing people to go back to say, how do we best provide affordable, accessible care? On something you said before about physicians, I see our data showing that those organizations, we're starting to see emerging trends and best practices. Physicians are actually leading, knowing that there is a primary care shortage, as well as they're in these shared risk models to say, we need advanced practice nurses. And I heard about 3 weeks ago, president of a large medical group, 1,000 employed medical and about 300, we want to be the place where advanced practice nurses want to practice because that is our future. So we see physician leaders realizing that that really is what is important for patients and for their organizations as they move forward.
Many of you may know just today Anthem is announcing an arrangement in Los Angeles with a number of the prominent health systems to provide essentially an accountable care organization type product aimed at narrower networks with lower cost care. It's impossible to imagine how they're going to do that without making lots of use of advanced practice registered nurses, so that would just speak to just exactly what you said, Trish. All right, now as we move to wrap up, I'm going to ask you each, all of you, to address a question. Please keep your answers about Twitter length, because everybody wants to get to a coffee break here. But if there were one thing that you all could do, hopefully together, to push this along, to basically, so that if we came back a year from now, we would concur with, I think it was Randy, you said, things are moving, or maybe it was Andy, things are moving in the right direction. Well, if we want to guarantee that we're back here a year from now and we can say, yes, they did, they moved that way from 2014 to 2015, what would be the most important thing to accomplish? Mary, we'll start over here with you.
I really think it's just to continue the conversation, first of all. I think it's through the conversation that people get educated and we raise the concerns. I think there's a couple things we need to do, even though there are more nurse practitioners graduating from school. There's still not enough. And I think that we have to create nurse residency programs and incentives to move nurses into that field. I think the biggest way to help solve this gap and problem is to, to have more nurse practitioners or more APRNs. I think that's essential. So anything that will make that happen should be created.
Okay, we're going to bounce over here to Trish.
Again, I think it's the dialogue. Keep the dialogue going. I think make decisions based on data. And I think many organizations don't even know quite what's going on in their organization. So how do you clarify that and then get champions to actually create those cultures, create those dialogues, and really, as Dr. McClellan said, focus on the entire provider team.
Okay, Randy.
Part of this is exactly what we're doing here today. One, you make a compelling case, and I think we do in fact have a compelling case for potential impact on, again, the intersection of quality and cost, What the current term is socialize. You communicate the case to all parties that are interested, and all parties are important, to government, to health plans, to medical societies, to hospitals. You communicate this case and keep keep working on it. You will move the system to your side over time. Sometimes when you're working in this area, if you're looking at it day to day, it does not seem like anything is happening. But if you look over a period of time and look back, you do recognize that changes do happen and progress is in fact made that way.
Okay, Kevin.
Yeah, so I'll echo Tricia's comments that it's a workforce issue. It's about the provider team. And I think the more that nurses and advanced practice nurses can be presented as a solution to a problem that's very real for individual consumers, so the transparency to consumers of what that solution can provide for them, as well as to our legislators, our employer groups, and I would say to a certain extent some healthcare organizations.
And Andrew, you're with the Minute Clinic, but we're going to give you less than a minute to put the last word on this panel.
Let's say we're incredibly proud of our 2,500 nurse practitioners. Certainly the work to standardize some of the requirements among the states, the workforce development that you alluded to, opportunities for leadership are incredibly important. And as we get to innovative models in the future, have ways in which they are recognized and rewarded and structured in such a manner that they can be implemented to provide the best care at the lowest cost.
So I think you all have heard from this panel, which did a marvelous job of socializing these issues. Thank you, Randy, for introducing that term into that conversation. I think you've heard universally they see the incredible value that registered nurses and advanced practice registered nurses bring to their enterprises, to their businesses. They understand the data, they understand the compelling stories that can be told about the need to continue to expand scope of practice, continue to involve nurses in these integrated teams, and that really it is a key solution to achieving the goals of the triple aim. So as we adjourn now for a coffee break, join me in thanking this panel for a terrific discussion.
Thank you.
That was great. Thanks so much.